All right, so we're going to talk today about a couple different things. I'm going to try to get through 2 modules today. We'll see how we end up doing. They're both kind of short ones. But this is talking about the relationship between ventilation and perfusion. We've talked about alveolar mid-ventilation. We know how to calculate it. We know what goes into it, the effect of dead space on it. And then the other end of the spectrum is the pulmonary perfusion that you end up having. Talking about preload, afterload, contractility, all that stuff. Normal alveolar ventilation is about 4 liters per minute. Normal cardiac output's about 5. So if you take that relationship, magically it comes out to be 0.8. Okay? So the normal ventilation perfusion ratio is 0.8. There is obviously some variation that exists. They're both gravity dependent in the sense that more perfusion goes to the bases than to the apices, more ventilation goes to the bases instead of the apices, but they're not an equal rate of change. So what you end up having is a little bit more blood flow to ventilation at the bases and a little bit more ventilation than blood flow at the apices. In reality, there's a continuum that exists between a state where you have a VQ relationship of 0, a true shunt or absolute shunt, moving through relative shunt to a normal state, and then moving a little bit further to the situation where I have ventilation present but no perfusion. And whenever you divide by 0, it's undefined, and the symbol that they use is the infinity sign. 8 turned on its side. Ideally, the ideal VQ relationship would be 1, but because of the variation throughout the lung, it actually is a little bit less than that at 0.8. So shunt being where I have perfusion but no ventilation, a dead space being where I have ventilation but no perfusion. Okay. So I can think of a bazillion questions I can ask on that. The amount of alveolar oxygen you have is dependent upon 2 logical things: how much you're putting in and how much you're taking out. So if you increase, so that the amount of oxygen in the alveolus is dependent upon how much ventilation you have putting it in and how much perfusion you have taking it away. Same is true with alveolar carbon dioxide. How much is going to be able to diffuse across the alveolar capillary membrane is dependent upon how much you're bringing back and how much ventilation you have taking it away. So ventilation and perfusion are going to affect both those values, the alveolar oxygen level and the alveolar carbon dioxide level. Increase ventilation, put more oxygen in there, alveolar oxygen goes up. Conversely, we reduce ventilation, you'd have a reduction in alveolar oxygen levels. Perfusion, though, also has an impact in the sense that as I increase perfusion, I'm also taking more away, because I'm having a larger volume of blood moving through the pulmonary circuitry. I'm also extracting more oxygen into the bloodstream to be delivered to the tissues. Conversely, as I slow my perfusion down, I have less oxygen being removed, and relative speaking, it's going to be a little bit on the higher end than otherwise. Same kind of symbol can be expressed as far as carbon dioxide is concerned. As ventilation increases, carbon dioxide is eliminated. That's kind of the rule that we've had up to this point in time. Increase alveolar ventilation, decrease alveolar CO2 and arterial CO2 in the process. Conversely, if you hypoventilate, alveolar CO2 and arterial CO2 is going to rise. It's also, though, perfusion dependent. And this has kind of become more of interest in monitoring end-tidal CO2. Has Mary covered end-tidal CO2 capnometry yet? I got blank look, so I'm going to say no. Okay. We have the ability to monitor somebody's exhaled carbon dioxide content. So as you're taking a breath in and taking a breath out, your CO2 levels change. There's no CO2 in the atmosphere, so as you're drawing it in, it's virtually 0. And as you're exhaling, then, whatever is in your alveolus is basically being pushed out, and we can monitor that. We can monitor to tell it has a correlate to what the arterial value is. So end-tidal CO2, the CO2 at the very end of the breath, correlates really well with what is in the arterial system under normal circumstances. But it also correlates with perfusion. So as you have a reduction in perfusion, we can detect that by seeing the end-tidal CO2 value fall. It's a direct relationship there. Less CO2 coming back, less CO2 can be exhaled off. Does that make sense? Where we're seeing it used, though, is during CPR. When the rescuer becomes fatigued doing compressions, the end-tidal CO2 starts falling. Get a new rescuer on, comes back up again. So we can tell when we're doing ineffective perfusion by monitoring end-tidal CO2. Okay? Fascinating stuff that's going on with it there. But again, there's this relationship. The fact that you're altering perfusion, altering ventilation, is going to alter both the amount of alveolar oxygen, and therefore the amount of arterial oxygen, as well as the amount of alveolar CO2. So those situations where you have ventilation exceeding perfusion, these are what we end up having. Well, when ventilation exceeds perfusion, I have more oxygen being put into the system than is being taken out, so therefore the alveolar value gets higher. If I have ventilation exceeding perfusion, I'm also removing more CO2 than I'm returning, so I'm going to go ahead and have a alveolar value and arterial value that's going to be lower. And this is kind of what we end up seeing as our alveolar level gets higher. That usually means that the alveolar CO2 is lower. If you think of the alveolar air equation, it's kind of what would end up happening. If I have a lower CO2, I'm going to have less being subtracted from the barometric pressure times the FiO2. Remember that part? Yeah. Okay. Sure, Rick, whatever you say. And this would be the example of what you would have when you have a dead space situation. So here I have my venous blood coming back, normal PCO2 of 45, 46, normal PO2 of about 40, saturation about 75%. I have one alveolus here that's being ventilated and perfused, so there is some exchange of gas going on, so I end up with basically, well, here I have a normal ventilation. The other one, though, if you look at it, though, there's no CO2 coming back because there's a pulmonary embolus. There's a blockage of blood flow. So really there's no gas exchange that is there. When the gas then diffuses across, I end up with, for this alveolus, normal-looking blood gases, but this alveolus has a little bit different, and as they end up, excuse me, let me rephrase that. This alveolus has no effect because there's no perfusion, so it's not even involved. So it's all dependent upon what is going on with the normal alveolus. But if you look at the blood gases, they're not affected. They're normal blood gases. So in the face of a dead space, it doesn't really affect oxygenation. Okay. Looking at the converse, though, is totally different. Whenever I have a reduction in VQ ratios, this is where we're starting to approach that shunt picture. As ventilation becomes less than perfusion, more oxygen has the ability to be removed, and it's not being replenished by ventilation, so alveolar and therefore arterial values fall, and CO2 values will increase. And this is kind of what we have in the bases. In the most drastic sense, where I have a shunt present, I have an alveolus that's not being inflated but is being perfused. So here I have my venous blood coming back. My capillary, some of it's engaging in good gas exchange, but some of it is basically just passing through without having any effect. And the net effect is that you end up basically having an arterial value that falls. So again, that shunt is a definitive problem because it's allowing venous admixture to be mixed in with good arterialized blood, and PO2 falls. Bigger the shunt fraction, bigger the problem. So the more alveoli you have that are not they're not participating in gas exchange, the worse problem you have. In the normal case, there's a difference between what is going on at the apices and bases. This is why it's not exactly a VQ relationship of 1. It's a VQ relationship of about 0.8. And what you end up having is a normal mixing in the process. So it's a little bit of a higher PO2 in the apices, a little bit lower PO2 in the bases, all mixes together, and you come out with our normal values. 80 to 100 for PO2, 35 to 45 for CO2. Now, there is something else that I need to make mention of, and it's something called the respiratory quotient. It's a little bit different. This is talking about the relationship between how much CO2 is being produced to how much O2 is being consumed. Normal CO2 production is about 200. Normal O2 consumption is about 250. So the ratio between those two is magically 0.8. Just happens to be the same exact number. But this is also dependent upon energy use. So if somebody's in a hypermetabolic state for whatever reason, a burn patient, for instance, that value is going to change. Also changes with your diet. Proteins, fats have a RQ a little bit less than 0.8. Carbohydrates have an RQ of about 1. So if you're eating a high-carb diet, you're producing more CO2 in the process because your CO2 production is going to be a little bit higher than it's going to be basically equal to what your O2 consumption is. This plays a really, really, really big role when we talk about patients with chronic lung disease. Because you're basically, if you're feeding them a high-carb diet, they can't remove that CO2, so it's going to build up in their arterial system. And we've had situations where we couldn't effectively remove somebody from mechanical ventilators simply because of their diet. Put them on a low-carb diet and boom, we were able to wean them off. So there's really a couple of different relationships that you can end up having. A normal state, where I end up having my VQ of about 0.8. We talked about the ventilation exceeding perfusion, what we call a dead space. We can have a perfusion exceeding ventilation, which would be our shunt. Okay. Remember, dead space is basically where you have ventilation present, but no perfusion. Anatomic dead space, your trachea. Your trachea that has no ventilation going on unless you're really weird and got some little gas exchanging pouches hanging off the side, which none of us do. Okay? So that's anatomic dead space, ventilation without perfusion. Shunted blood is basically those situations where I have blood going from the right side to the left side without passing through an alveolus. The anatomic shunts, things like Thebesian veins, bronchial veins, pleural veins, those are examples there. There's also, in theory at least, what we call a silent unit. And a silent unit, I'm going to remain silent on because we don't really think about them. But if you have no ventilation and no perfusion, I guess I would kind of call that dead. But in theory, at any given moment, there might be an alveolus that is neither perfused nor ventilated. Okay. I don't know what the VQ would be in that case because it's 0 over 0. So it's kind of a not zero. Well, but it's not 0 because true shunt would be 0. This is kind of lost in its kind of own ozone lane. So dead space, again, are those situations where ventilation exceeds perfusion. And for right now, I'm not going to require you to memorize why that would happen, just that it does. But the classic example is a pulmonary embolus. Someone where a blood clot or some other substance obstructs the pulmonary blood flow, and you end up having alveoli that are ventilated but not perfused. You can also have that when you just have a reduction in overall blood flow, when we have destruction of the pulmonary vasculature, as we'll find happens in emphysema, and when you also have compression on those pulmonary capillaries due to increased alveolar pressure, as we see when we over-ventilate somebody. So in that situation is, again, that obstruction present. Shunted blood flow is where you have perfusion exceeding ventilation, as we've talked about. Anytime you have an ineffective ventilation going on, be it from an obstructive defect or a restrictive defect, you can end up having this happen. We talked about the surfactant deficiencies that you see in prematurity being an example of a large amount of shunt. There's our classic example. So it kind of gives us the spectrum that we end up having from an absolute true shunt to an absolute true dead space and everything in between. And again, there is this continuum that exists. What I might ask of you on a test is to calculate this. It's a real hard thing to do. Alveolar ventilation is 6, cardiac output of 4. What's the VQ ratio? Well, the V stands for ventilation, the Q stands for perfusion, so you just divide 6 by 4 to get 1.5. Now, I might also ask you, given that relationship, what do I have going on? A shunt, a dead space, or is a normal? Well, if it's bigger than 0.8, it's a dead space. If it's less than 0.8, it's a shunt. Okay. Does that make sense? Boy, that's awful. You guys can't even see that, can you? Oop. Oh, there you go. There's our Christmas. Let me go back here for a second. That's a whole lot better. Okay. Let me, all right, talking about control of ventilation. There's really a couple of different facets involved here. One is that there's a central control to the initiation of an impulse to begin contraction of the diaphragm. So we're going to call that the central controlling mechanism. It has output which then has some stimulation of the respiratory muscles or effectors. And then there's also some sensors or giving biofeedback back to the central controller about various aspects related to that ventilation. And we're going to find out that there's these some peripheral receptors and some chemoreceptors. So let me just go back, review a little bit about the central nervous system, specifically the medulla oblongata and the pons. The medulla oblongata, remember, is the lower portion of the brainstem. It's the part that is just proximal to the foramen magnum. So right after that begins the spinal column, so it's inferior to the pons, just below the pons, and it's just in front of the cerebellum. This is associated with basically a lot of involuntary reflexes that we have, like sneezing and coughing, and it's also where the cardiovascular and respiratory activity begins its origin. There are two groups of neurons, and for the most part, I just want you to know the names, because a lot of this we're still figuring out as we go along how they function. But there's a dorsal respiratory group and a ventral respiratory group. And the dorsal is primarily inspiratory cells that begin the innervation of the inspiratory muscles. And they do have also some input from the cranial nerves to allow us for, and from the cerebral cortex, which allows for voluntary changes to that. The ventral will have basically both inspiratory and expiratory. So here's where it's located at, just proximal to the pons. And I think this is out of your text. So we kind of got an idea of where we're talking about. But right now, I just want to talk about the medulla oblongata. There's these dorsal and ventral. And the blue ones are inspiratory neurons, so they're primarily inspiratory neurons in the dorsal, and then there's some inspiratory and expiratory in the ventral. I have no idea who Botzinger's complex, who Botzinger was, but he sounds like a pretty cool dude. Okay. So dorsal and then ventral. The pons is located above the medulla oblongata, and it has two centers also that I want you to know the names of. One is called the apneustic center, and one is called the pneumotaxic center. So the impulses from the medulla oblongata, from the dorsal group, sends out an impulse to the diaphragm to begin contraction. The apneustic center basically then takes over and says, okay, Mr. Impulse, you've been going long enough, I'm going to cut you off. So something's got to start the impulse to breathe, and something's got to stop that impulse from continuing to innervate the diaphragm. The thing that causes it to stop is basically the apneustic center. There's also another portion of this called the pneumotaxic center, which basically is fine-tuning that impulse being sent out through the inspiratory centers. So here's the pons, lower on top, the pneumotaxic superior to the apneustic center. And there's the two of them as far as what they primarily look towards. Okay. Anytime you have a situation where the respiratory centers have reduced blood flow, you're going to have reduction in ventilation. Okay, to the extent that if it gets, in this case, as I'm mentioning there, about increased pressure causing cerebral edema, if you have a closed head injury and the brain swells, it's a fixed space that doesn't have a whole lot of room for swelling. So what ends up happening is the swelling brain begins to push the medulla oblongata through the foramen magnum, which there's not enough space for it. So what ends up happening is the foramen magnum compresses the medulla oblongata, blood flow to that area is cut off, that tissue dies. Okay? So basically now you have no impulses telling you to breathe. Okay? This is what we classify as brain death. Okay? Again, as long as that heart is continuing to receive oxygenated blood, it'll beat forever. Well, I'm exaggerating there a little bit, but it'll continue to beat for a long time. In this case, what you end up having, though, is loss of all cerebral function. So all cognitive function's gone, their EEG is flat, they're brain dead. The only thing that's keeping them alive is us, ventilating for them. Similar kinds of things can happen where you have things like acute poliomyelitis and certain drugs that can end up depressing the respiratory centers. So you end up having basically an inability to breathe secondary to the fact that the respiratory centers are blunted. They've kind of gone to sleep. Okay, we talked about some of the peripheral chemoreceptors, I think, previously, or maybe we haven't, but there are some central chemoreceptors that are present within the medulla of the brain. And let me go through this, and hopefully it'll make a little more sense as I go through. This is basically talking about what stimulates you to breathe. Within these, within the cerebral spinal fluid, gas is allowed to diffuse across, but ions are not. Okay, so hydrogen ions can't move across, but CO2 can. Well, if you remember that anytime you have CO2 and water present, you're going to create those hydrogen ions. It is the hydrogen ions that actually stimulate the respiratory centers and medulla oblongata to begin a breath. So when those hydrogen ions go up and the pH goes down, ventilation begins. Think about what's happening here as you're sitting there. In between breaths, your CO2 levels very slowly begin to climb up. It's not even noticeable to us, but as our CO2 levels rise, CO2 diffuses across the blood-brain barrier into the cerebral spinal fluid. That CO2 reacts with water to form carbonic acid, which forms hydrogen ions. Those hydrogen ion concentration now increases in the cerebral spinal fluid and stimulates the medulla oblongata to say, hey, take a breath. So that CO2 level slowly climbing is what begins the process of us saying, hey, take a breath. Make sense? Okay. So that's how the control of ventilation is managed. And this is kind of a drawing of it, again, it's out of your text. But you can see that these ions are impermeable to that blood-brain barrier, but CO2 can get across, creating the hydrogen ions, stimulating those portions of the dorsal and ventral respiratory groups within the medulla oblongata. These are called central chemoreceptors. They're responding to chemical changes, specifically the pH of the cerebrospinal fluid. There's also some peripheral chemoreceptors. These are located the same place as those peripheral baroreceptors we talked about previously that regulate blood pressure and heart rate. These regulate ventilation. The carotid bodies, again, located in the internal, external carotid arteries, and they basically transmit the impulse back through the glossopharyngeal nerve, the ninth cranial nerve. Aortic bodies transmit them back through the vagus nerve or the 10th. These respond to both oxygen, carbon dioxide, and pH, but primarily oxygenation. So when you start getting a PO2 less than 60, your brain says, I think we probably should be ventilating a little bit more, so it stimulates us to breathe deeper and breathe faster. Okay? It's not a perfect system, and when you get to a drastic hypoxemia, it kind of just goes to sleep, but then again, probably so do you at that point. And what happens when they're stimulated is it increases your respiratory rate and your tidal volume. And again, the key part here is that response is to PaO2, not oxygen content. So in the face of anemic problem, it's not going to be responsive. So there they are in the carotid bodies and the aortic bodies. Basically, if it's saying I'm not getting enough oxygen to my blood and to my, not getting enough oxygen in the blood going to my brain and to my heart, I'm going to stimulate you to breathe. This is just kind of showing that you end up having, whenever you have alveolar hypoventilation present, you probably are increasing your shunt fraction, stimulating then these two, there's hypoxemia present at those two spots, stimulates us to breathe and increase ventilation. So it's kind of a nice biofeedback mechanism there that says, I'm going to go ahead and increase ventilation. So far, so good? Okay. So important takeaway message. When you were young and you wanted that toy, and you said, I'm going to hold my breath until it doesn't work. You eventually pass out, your brain says, hey, stupid, I'm going to breathe. Don't be an idiot. Okay. There's also some reflexes that are involved that are kind of feedback mechanisms or reactionary mechanisms to alter ventilation also. The first one of which is a Herring-Brewer reflex. And this is basically an overstretch reflex. It's a mechanism by which your brain says, stop taking air in. I have a big enough tidal volume, I don't need any more. Okay? So when it basically tells the inspiratory centers to stop telling the diaphragm to continue to contract. It inhibits large tidal volumes. There's also a deflation reflex, where basically when the lung is deflated due to atelectasis, due to pneumothorax, we end up having tachypnea. I guess it makes sense, but don't really know why this deflation reflex occurs. So there's Herring-Brewer's overinflation, and there's also one for when we deflate. There's also some irritant reflexes that are present within the tracheobronchial tree, the upper airway, as well as the lower, some portions of the lower airway that stimulate a vagal response. And basically they're stimulated due to a couple different things. If I start putting some a laryngoscope into your airway and try intubating you, it's not a natural process. You're going to react to it. Same thing would be true if you were home cleaning and you took some bleach and some ammonia and you mixed them together, and making this noxious gas. Same kind of problem would happen. And same is true as if in a reactive airway person who has irritated airways, if you give them something to stimulate bronchospasm, you'll end up having a response also. But basically the response would end up being that you're going to increase your respiratory rate, you're going to cough, sneeze, gag, all those kinds of things to get rid of this irritant that is being introduced into the airway. So it basically affects ventilation by saying, stop. Another receptor that is there are called J receptors, J standing for juxtapulmonary. You think of it, it's just next to the pulmonary capillaries. So they're located in the interstitial space between the pulmonary capillary and the alveolus. And basically they respond when you senses an increased pressure in that spot, which normally it's a very small amount of fluid in there. But if there's, due to pulmonary edema, a large amount of fluid moving out of the pulmonary vasculature, moving into the interstitial space and eventually flooding the alveolus, it'll go ahead and stimulate a rapid shallow breathing process. Okay, so J receptors. And I think this is the last one, the paradoxical reflex of head. I don't know who the hell Head is, but he was somebody who first described it. And it basically stimulates a deeper breath, which can account for what we think goes on when you have a sigh or a yawn or something along that line. It also apparently has something to do with the initial breath that is created when you first are delivered outside of mom. Okay. I think this might be blown up in the back, but it kind of summarizes everything that you can think of. Where do I start on this? Holy moly. Your peripheral chemoreceptors stimulating due to a reduction in oxygen, stimulate ventilation back to the respiratory centers. You can have, when a ventilation is being given, if there's something that's causing an irritable response, there's irritant receptors. There's stretch receptors, those Herring-Brewer receptors within the lungs. There's also the thing to remember is that you can have a conscious control of ventilation. You can, due to emotions, hyperventilate. Due to pain, hyperventilate. So there's other reactions other than the control through the normal process that are there. Okay. I think we'll leave it there.